Hello everyone. My name is Simran Chaudhary and I welcome you all on behalf of Voice of Healthcare to today's session on ABG Insights at the Point of Care, Improving Critical Decisions, organized by Voice of Healthcare and supported by Radiometer, a knowledge-driven series that brings together leading voices from the front line of healthcare. In this session, we'll be diving deep into the critical role of atrial blood gas interpretation in acute and intensive care. As every second counts in critical care, the ability to interpret ABG results swiftly and accurately can often be the difference between timely intervention and missed opportunity. This session is designed to empower healthcare professionals with practical insights, real world case analysis, and best practices to sharpen decision making at the point of care. And for this session, we are privileged to have two highly respected experts. Dr. Sanjith Saseedharan, Director Critical Care, SL Raheja Hospital, a Fortis Associate, Mumbai. Welcome to our show, sir.
Thank you.
Thank you so
Agree.
much for joining. Thank you so much, sir. Dr. Kinjalka Hosh, Professor Clinical Biochemistry, Tata Memorial Hospital, Mumbai. Welcome to our show, sir.
Thank you. Thank you so much.
Thank you so much for joining, sir. And in this session, they will guide us through key discussion points that include simplifying ABG interpretation in fast paced clinical environments, applying ABG insights in critical decisions, integrating these learnings into everyday workflow. And let's begin this important conversation, which will enhance and it will help us understand the patient centered point of care excellence. So, without any delay, I'll just give a brief. So, we have two presentations by both the speakers. I would like to invite Dr. Sanjith Saseedharan for his presentation. And the topic of his presentation is clinical interpretation of ABG in high stakes situations. So, over to you.
Okay. Is my slide visible?
Correct, sir. Visible.
Yeah. So thank you, Simran, for the kind introduction, and welcome to whoever is tuned in for this webinar on arterial blood gas analysis. I've been told to talk about how you interpret these blood gases on a day-to-day basis and deal with some cases that would be commonplace in the intensive care unit. Well, this is how a blood gas report looks like. And what I've shown you on the screen is exactly what the blood gas is all about. Now, if to interpret a blood gas is actually not anybody's cup of tea. It requires a little bit of knowledge of understanding what these numbers are all about. So let's look at each of these numbers per se. Okay, so what is this? The one of the most important numbers that we look at over here is PO2, that is partial pressure of oxygen inside the blood. Now, this partial pressure of oxygen inside the blood is actually the amount of dissolved oxygen. That means how much oxygen is dissolved in the blood is what is seen as a partial pressure, which is called as PO2. Remember this is only 1 to 2%. Only 1 to 2% of the total oxygen inside your body. This is PO2. So you might wonder how such a small amount would actually make a big difference when it comes to blood gas interpretation. What you see on the side is also the normal values as 83 to 108. In this, it looks like it is 152. The PO2 here is 152. So I repeat again, partial pressure of oxygen is a dissolved oxygen in the blood. And to understand this, we also need to understand the oxygen cascade. Now, if you will be bewildered to know that outside, I mean in the atmospheric air, the amount of oxygen that we have, PO2 there is actually 160. You can see on the screen is 160. And as it goes into the alveolus, it actually goes down to 150. As it go to arterial blood, it becomes 100. What you're seeing there as normal figures around 183 to 108. And once it comes to the capillaries, it's tissues, it's around 30. And once it comes to the mitochondria, it's barely 10. This means to say that the mitochondria gets 0 to 1 to 10 mm of PO2, whereas what's there in the atmosphere is 160. So looking at it, that's why that figure 83 to 108 comes there. That's normal PaO2, or what we call as PO2, which is the capillary oxygen. This is the capillary oxygen, thus remains 83 to 108, even though the atmospheric oxygen is 160. The one that goes to the mitochondria is barely around 1 to 10, and that's where most of our oxygen kind of works. So what is the significance of knowing a PO2? It's because we need to understand all the tension indices of oxygen are actually dependent on this number PO2. So when we talk of PaO2 FiO2 ratio, it means the amount of oxygen that is there inside the alveolus versus amount what is there as what you're providing. That's PF ratios. There's something called PaAO2, that is alveolar arterial oxygen gradient, that is P small a divided by P big A. These are all oxygen tension indices which give us a lot of information about what is happening inside the body. We also have to understand its relation to the SO2. Now let's understand SO2. SO2 is over here. This is over here. It is shown as SO2 98.9%. There is a difference between PO2 and SO2. This is what is SO2. SO2 is oxyhemoglobin divided by oxyhemoglobin plus deoxyhemoglobin. This means to say one molecule of hemoglobin binds to 4 units of oxygen. When it is completely saturated with oxygen, it's called 100% saturation. Some of them may not be binding. That's called deoxygenated hemoglobin. When we make a ratio out of this into 100% and divide into make it to a percentage, we call it as SO2. And what you see down there is actually called as the oxygen hemoglobin dissociation curve, where you have PO2 on the x-axis and SO2 on the y-axis. So if you see 0 0.1, 0 0.2 up to 100%, whereas down you see 20, 40, 60, 80 to 100. When you notice this, 97% of oxygen, when you say SO2, 97%, which is found by pulse oximetry, also a non-invasive device which we all know after COVID. By pulse oximetry, we find 97% oxygen, and at that time the PaO2 is close to 100. So that means if it's 100, which we saw as normal, 83 to 103 is what we saw as normal on that blood gas meter report that we had. 97% will be your saturation. If it drops down, that means if you take it from a vein, we have taken all the oxygen that we have, all these blood gases are done from the artery. If you take it from the vein, what you get is somewhere around 75% as your saturation, and that's where it is around 40 to 45 when it comes to PO2. That will be when it comes from a vein. Well, what is the significance of this? The significance completely depends on the same oxygen hemoglobin dissociation curve. If you look at the curve is something like this, isn't it? So over here, if you look at say around somewhere around 80, which we have said as normal, lower limit of normal 83, 80. So say around 75% if it is, you have it to be somewhere around 95%. But the moment it goes less than 75, you see it tremendously dropping down. This means to say up to a saturation of say around 93, 92, we probably can correlate that to the PaO2. But the moment it goes, the PO2 gets less than that, there's going to be a sharp decline of the saturation, indicating that the delivery of oxygen is actually going low. Remember this, SO2 is responsible for delivery of oxygen. PaO2 is just a number that tells us this much is the oxygen that is dissolved in the blood. And that is the reason that we want to correlate this. And that's why you must remember that once the PO2 goes less than 75, there is going to be a sharp decline in the SO2, indicating a loss of delivery to the body. Well, now look, what is this FO2HB then? In the blood gas meter, you also see something called as FO2HB, and it's mentioned as 96.7. It is lower than that the SO2 had. The SO2 had 98.9 if you see on top, whereas the FO2HB is 96.7. What is this? This fraction is basically the addition of deoxyhemoglobin plus the methemoglobin and the carboxyhemoglobin. That's what the FO2HB is. We do have a small amount of methemoglobin in our body, and that's what when you add it on, it actually changes the ratio. So this means to say, if you have patient with dyshemoglobinemias like methemoglobinemia or things like that, there would be a drop in the FO2, thus indicating this kind of dyshemoglobinemia. Meanwhile, you must also understand that if you have a patient that has gone is in a burning building and comes to you, the carboxyhemoglobin will go up. You will see the change from this FO2HB. So the the ABG will actually show you this this figure, and you should be aware of what this FO2 is all about. But remember this. All these things have to be interpreted in the context. For example, when you look at the PO2 over here, it was 152. You would think that this is normal. Okay, do you think that this is normal because 83 to 108 is normal, but your PO2 is 152? But look at this patient. This patient is a 48-year-old male. He has history of breathlessness. He has fever, a BP of 90 systolic, and a pulse rate of 132 per minute. And when this patient has come to the casualty, they put this patient on a high flow nasal cannula with an FiO2 of 100%. That means this patient received 100% oxygen to get this PO2 of 152. And now, in the context of this PO2 becomes very, very abnormal, because you should have had a PO2 of somewhere at 400 to 500 in this case. That means when you are delivering an oxygen of 100%, the PO2 should have been somewhere around 400 to 500, or around 4 times the FiO2 is what you will have the PO2 as. So looking at this, now suddenly this blood gas becomes very, very abnormal, indicating that there is some sort of oxygenation deficit for this particular patient. This is how you will interpret a blood gas. You will never interpret a blood gas just with these numbers. You have to interpret the blood gas on the context of this particular patient. And this is what this patient was. This was a case of COVID ARDS. ARDS that is seen on your X-ray means the entire lung was full of patches and the oxygen was not diffusing through. And that's why he required an FiO2 of 100% to give a PO2 of 152. Let's go to the other numbers. So the most important numbers that you will deal with apart from PO2 in the blood gas is pH and PCO2. Now look at this. How do you look at the pH and PCO2? The pH over here is 7.497, PCO2 17.7. Well, low pH simply is acidosis. High pH is alkalosis. Anything less than 7.4 is acidosis. Anything more than 7.4 is alkalosis. Now, how do you interpret the PCO2? The PCO2 actually gives us the ventilatory function. When we say type 1 respiratory failure or type 2 respiratory failure, these are the two ventilatory functions that will come to. And as we go ahead, we'll understand how to interpret this PCO2. Remember this, there is also another figure called as bicarbonate in our body. These bicarbonates in our body combine with carbonic anhydrase to form CO, combine with water to form CO2 and H2O, and then liberate hydrogen ion and HCO3. This is also there in our body. This bicarbonate helps to keep the pH in its normal range. And if you look at the ABG value, you'll find two kind of bicarbonates. You'll find HCO3P standard and you'll find the HCO3PC. Now, what is the difference between both? Well, when you have a patient who's not stressed, who's not receiving any treatment, who has oxygen, who's not on oxygen, anything like that, the bicarbonate P would be the bicarbonate value in his plasma, in his blood. This is what his bicarbonate would be. However, we want our bicarbonate to be standardized with respect to the carbon dioxide and the temperature. And that's why when we interpret blood gases, we look at the standardized bicarbonate, which we call as P.STC. So the standard bicarbonate is what you need to check when you're actually looking at blood gas meters. Well, we also see a base excess over there, which simply means the deficit of negatively charged ions or a reduction of the bicarbonates that are there. And we have something on the blood gas called as lactate. Now, lactate is a very important parameter. In the last 8 or 10 odd years, lactate has been used extensively. Now, remember this, there is something called lactic acidosis and there is lactic acidemia. Now, this lactic acidosis, basically this lactate has got two optical isomers. One is called as the D-lactate, which comes from the liver, and liver issues will actually cause the D-lactate to go up. And the other is called as L-lactate, which is the major part of your lactic acidosis. Whenever we are looking at lactic acidosis, we're looking at L-lactate. Now remember this, lactic acidosis is of two types, type A and type B. When type A comes, it means there is an inadequate tissue oxygenation or inadequate perfusion. This means to say the heart is barely contracting. If the heart is barely contracting and the amount of blood going to the tissues are alarmingly low, then that tissue will not get oxygenated because there is no blood going to that tissue. That would occur with inadequate perfusion, which will lead to type A lactic acidosis. Whereas type B is the one that is not related to this kind of mechanism where there is a reduction in oxygen supply to the tissues. And normally, the biggest thing that we have in our country is usually sepsis. So lactate in sepsis, first of all, remember, is not due to anaerobic metabolism. Lactate in sepsis is due to stimulation of beta 2 receptors. Let me explain to you this. Whenever there is a sympathetic stimulation, there's going to be an increased release of epinephrine. Epinephrine stimulates the beta 2 receptors, which will then release cyclic AMP, which works a long deal to improve the sodium potassium ATPase pump. This per se then works on the glycolytic pathway, causing the production of glucose. Now, when this glucose production is formed, glucose uses this ATP, ADP, and thus forms pyruvate, which then enters the TCA cycle. However, when the production of glucose is very high because beta 2 receptors are stimulating very highly, then at that stage, the amount of pyruvate conversion moving into TCA is so much that it is unable to get into that cycle and it then converts into lactate. This means to say more the epinephrine, more the beta 2 receptors, more the cyclic AMP, very large the pyruvate, more the lactate. This means to say more the sympathetic stimulation, more the lactate. This means to say that when you have too much of beta 2 receptor stimulation, you will get increased lactic acidosis, and that is what actually happens in sepsis. And it is not due to anaerobic metabolism, but due to overstimulation of the beta 2 receptors that we have in sepsis. And in fact, this might be a beneficial compensatory response. However, all said and done, lactate is equal to badness. Whenever there is going to be lactate, it means there is something really wrong with the body and the body is fighting to keep this all intact. So how do we use this lactate in our ABG? How to use them in sepsis per se? Well, there is a third international consensus definition that came out from sepsis and septic shock, which actually says that sepsis plus, if you require a vasopressor to keep the BP more than 65 plus lactate, you can call it a septic shock. This is what is the definition of septic shock. So to define septic shock, you need the presence, at least presently, for lactate more than 2 millimoles per liter. Well, what about in sepsis? If the lactate is high, there is a suggestion that this might be sepsis, but you cannot prove it to be sepsis because lactate on its own, if you look at the lactate on its own, has an odd ratio of 1.44 with an optimal cutoff of 1.3 in diagnosis of sepsis. But if you were to actually increase this cutoff to 1.9, then the odds ratio goes up. This means to say that the sensitivity of lactate at a 2.5 millimoles per liter is somewhere around 29.5% with an accuracy of 64.6% to diagnose sepsis. This means to say lactate cannot be used specifically to diagnose sepsis. However, increase the normal lactate level significantly increases or decreases the likelihood of a final diagnosis of sepsis. Importantly, it is not sensitive or specific to rule in or rule out diagnosis on its own. It can be used as supportively when it comes to sepsis. Now let's get to interpreting blood gas measurements. Okay, this is how the blood. The first thing in this is it involves totally 4 steps. The first step is find the primary disorder. The second step would be find the response to that disorder. The third step would be evaluate the gap if it is metabolic acidosis. And if it is metabolic acidosis, we actually figure out the gap. These 4 steps will actually completely make your interpretation of blood gas as simple as possible. Now let's go to it. How do you do step 1, primary disorder? Let's look at this same blood gas. You have a blood gas over here and you look at only the pH and PCO2. So let's take the example of how to set the primary disorder. Look at the directional change. Okay, if the directional change of pH and PCO2 is the same, the primary disorder is metabolic. If the directional change is opposite, the primary disorder is respiratory. That means if the pH goes upwards, PCO2 goes upwards, it is metabolic. If pH goes upward, PCO2 goes lower, it is respiratory. Simple. Now look at the example number 1. In example number 1, you have pH going down, PCO2 going down. It is going in the same direction. In example number 2, you have pH going up, PCO2 going up. It's the same direction, though this is metabolic. And the first example is acidosis because pH is going down, and the second example is alkalosis because pH is going up. This as simple as that. This basically tells us it is metabolic acidosis or metabolic alkalosis. Look at the example 3. In example 3, you have pH going down and PCO2 going up. It is changing in the opposite direction. This indicates a respiratory problem, and the directional change that you have tells us whether it is acidosis or alkalosis. Example 3 now obviously becomes acidosis, and example 4 becomes alkalosis over here. So respiratory acidosis and respiratory alkalosis. As simple as that. Well, sometimes what does happen is either the pH is normal and or the PCO2 is normal, indicating a combined disorder. So if they are not opposite changing or going in the same direction, one remains normal, then we call it a combined disorder. And in a combined disorder, what's usually occurring is that there is one respiratory alkalosis with the opposite, metabolic acidosis, or respiratory acidosis with metabolic alkalosis, the opposites. Similarly, if it's metabolic acidosis, it will be respiratory alkalosis. So if the pH tries to come towards normal as much as possible with compensation, and that's what a combined disorder is all about. Well, that's about primary disorder understanding. Now let's understand response. This is very, very important for us to understand what is the response. Well, let's look at this. When you look at pH and PCO2, we can figure out the directional change and figure out whether it is metabolic and respiratory. That's our first thing that we need to do. So what is the let us look at this. What is the directional change over here? The pH is 7.32, the PCO2 is 23. It is both changing in the same direction. 7.3 going down, 23 going down. So the primary disorder is metabolic, and because the pH is going down, it now becomes metabolic acidosis. This is what the response is. Well, now let us go. Or this equation is something that we have to remember. In the event that there is metabolic acidosis, we need to change the PaCO2 to remain alive, and that's what we want to do. Expected PaCO2, we have to find the expected PaCO2, which is equal to 1.5 into bicarbonate plus 8 plus or minus 2. This equation you have to memorize. 1.5 into bicarbonate plus 8 plus or minus 2. Now let's just replace the bicarbonate from the values that we have. It's 15. So when we replace it by 15, what you get is 30.5 plus or minus 2. Now, what you are seeing is the measured PCO2 was 23, whereas what you have expected was 30.5. This means to see the measured PCO2 is less than the expected PCO2, indicating there is an additional respiratory alkalosis. That means the patient is trying to breathe very, very fast, and that is why there is an additional respiratory alkalosis. So this disorder now becomes primary metabolic acidosis with superimposed respiratory alkalosis. This is how you would actually find the response per se. Now, this is in cases of metabolic acidosis. What if it is alkalosis? What if it is alkalosis? If it is alkalosis, very simple. The same equation is replaced by a 0.7 and a 21. And you do the same thing. You find the expected PCO2 and find out whether it is matching it. If it is matching, it is primary. If it is not matching, then there is a superimposed disorder, either acidosis or alkalosis over there. That's about the response. Okay, now that we've understood how to find out primary disorder and how to find the response in metabolic acidosis, the other thing is to evaluate the gap in metabolic acidosis. We are still in metabolic acidosis. Okay, so how do you evaluate the gap? The gap will figure out only when there is metabolic acidosis. What is the gap in the first place? So on your blood gas, look over there. That is your gap, the anion gap. The anion gap is nothing but a rearrangement of the electrochemical equation which is there in our body, which is called sodium plus unmeasured cations is equal to chloride plus bicarbonate plus unmeasured anions. And if I were to rearrange this equation, unmeasured anions minus unmeasured cations, which is basically the gap, the anion gap. That means unmeasured anion excess that is there is equal to sodium minus chloride plus bicarbonate, which is given directly on the blood gas meter, of which the normal values will be 12 milliequivalents per liter. If it's around 12, it is said to be normal anion gap. This is normal anion gap. And sometimes in certain conditions, when the albumin is extremely low, something less than 2 or something like that, you need to adjust that anion gap. And the equation over there is observed anion gap plus 2.5 into bracket 4 minus 5 minus measured albumin. This is the anion gap. Remember this, if the anion gap has gone more than 12, it is called as high anion gap metabolic acidosis. High anion gap. If the anion gap is low and it is metabolic acidosis, it's called normal anion gap metabolic acidosis. However, after you evaluated after the primary disorder, seen the response, evaluated the gaps, if the gap is high, you need to actually do something called as the gap. Now, what is the gap? The gap is an equation called as measured anion gap minus 12 upon 24 minus bicarbonate. This is also sometimes called as delta gap. Okay, that means you're finding out the high anion gap minus 12 divided by 24 minus bicarbonate. And very simple interpretation. If the gap is less than 1, it means there is a coexisting non-anion gap metabolic acidosis. That means normal anion gap metabolic acidosis. And you have a gap more than 1, it means there is a coexisting metabolic alkalosis. So if in a case of metabolic acidosis, you first evaluate the primary disorder, then look at the response, look at the gaps, and then look at the gap to actually understand how to interpret a blood gas when it comes to metabolic acidosis. Now let's go to a completely different scenario. Let's go to respiratory. Till now, we talked about metabolic. Let's look at respiratory. And we just discussed that when they move opposite, pH and PCO2 moves opposite, it is called as respiratory acidosis or respiratory alkalosis. For example, look at the example one, pH 7.1 going down, PCO2 going up. It's moving in opposite directions. And that is why, since it's moving in opposite directions, it is called as respiratory. And the directional change of the pH again will tell you whether there is acidosis or whether there is alkalosis. So this is what you're seeing. So in the respiratory issue, whenever there's a respiratory issue, once the moment you find the primary being respiratory, the expected compensation is pH. That's why in acute respiratory acidosis, this is the expected pH you'll see. 7.5 minus 0.008 into PaCO2 minus 40. This is what the equation you have to remember when it comes to respiratory acidosis. When it comes to respiratory alkalosis, a small change, everything becomes plus, and the PaCO2 gets interchanged to 40 minus PaCO2. And when it comes to chronic conditions of respiratory issues, then it will be 7.4. The only thing that changes is 0.008, which is replaced by 0.003. And respiratory alkalosis, again the same thing, just 0.003. And since alkalosis, we want the pH to go higher. So at the end of the day, you just need to remember one equation, 7.4 minus 0.008 into PaCO2 minus 40. The rest all will come just by logic. So it's not very difficult. It's very, very simple. And then you look at this expected pH and compare it to the pH that you have measured on your blood gas meter. If it is low, means there is superimposed disorder. If it is high, that means superimposed disorder. If it is equal, it means there is no superimposed disorder at all. Well, let's now go quickly. We have very less time left. So let's go quickly into a case. Now, this is a case who presented to the casualty with weakness of both limbs since last 4 days. It started with a tingling sensation of both the limbs, otherwise a fully conscious individual with a pulse rate of 120 and BP 150 by 80. There is an absence of reflexes. He is conscious, he is obeying commands. Sensation is reduced in both limbs, and there is no sensory level as such, and there is no cranial nerve involvement. People working in medicine would realize that this is a neuromuscular junction problem, and this is likely to be a condition called as Guillain-Barré syndrome, where there is ascending paralysis slowly and slowly affecting the diaphragm. Since it's affecting the diaphragm, the ventilatory functions are the ones that are going to be affected. And this is his blood gas. Look at his blood gas. Now let's interpret this blood gas for us. Well, what's the primary disorder? We follow the same 4 steps. What's the primary disorder? The primary disorder looks like, now to remember what the primary disorder was, look at this. The primary disorder depends on the directional change. Over here, it is opposite. So the problem here is respiratory. So let's look at it. It's respiratory acidosis because pH is going low, PCO2 is going up. Directional change of pH is downwards. That's why it's respiratory acidosis. Now, we just now discussed what's the response. Now, if it is acute respiratory acidosis, we have to figure out the expected pH, which comes from this equation, 7.4 minus 0.008 into PaCO2 minus 40, which now, if you put it over here, let's put 75 because the PaCO2 is 75 here, minus 40. What you get over here is 7.12, which is almost equal to the pH over there. That means it's superbly compensated, and that's why this expected pH is 7.12. That's why this is called as acute respiratory acidosis. This is the terminology you'll give to this particular patient. And what would be the treatment of this? The treatment of this would be to remove this carbon dioxide out. And why is the carbon dioxide accumulating? Because the diaphragm is unable to move up and down because of paralysis. And so what do you do in these patients? Put them on a mechanical ventilator that will wash out the carbon dioxide and get the pH back to normal. So this is an interpretation of the blood gas per se over here. Well, let's look at another one. This is a patient who basically admitted to the casualty with diabetes and heart failure with reduced ejection fraction. Patient was already on Lasix and valsartan sacubitril, which is the drug that you give for patients with heart failure and reduced ejection fraction. And when he presented to the casualty, he has presented to the casualty with some amount of confusion. Patient had 8 episodes of profuse vomiting after eating a meal outside. Looks like some kind of food poisoning. Pulse rate was 120. But to 90, which was irregular. That means some sort of rhythm disturbance has occurred. The BP was 150 over 80 millimeters of mercury. There was a very dry skin and dry tongue, noticeably because of so many episodes of vomiting. But however, the patient had crepitation on both the lungs with saturation of 90%. Now, the moment a casualty medical officer sees crepitations on both the lungs and a saturation on the lower side, the response, knee-jerk response, is actually to give Lasix. So the patient actually received Lasix 80 milligrams in the casualty and then was shifted into the ICU. The moment the patient was shifted into the ICU, this is the blood gas. Now let's follow this again. What's the primary disorder here? Now, to understand this, we must understand the pH and PCO2 here, where the pH is going up and the PCO2 is going up. If the pH is going up and PCO2 is going up, that means going the same direction. It is a metabolic problem. And the directional change of pH tells us whether there is acidosis or alkalosis. So the pH is going upwards. That's why it's called as metabolic alkalosis. Now let's look at the response. What's the response? Now for the response of metabolic alkalosis, I'm just showing you the earlier slide that we had, was to use expected PaCO2 into bicarbonate plus 21 plus or minus 2. This was what we used for it. So let's put that over here. Zero point 0.7 into bicarbonate plus 21 plus or minus 2. The bicarbonate over here that we are seeing is 44, 43.8, that is 44. So when we add this over here, we get 49.8 to 53.2. What is our PCO2 over here? 51. This means to say this is acute metabolic alkalosis. Probably this would have occurred because of the fact that the patient was throwing out so much of vomitus that he lost so much of hydrochloric acid from his body that he became kind of alkalotic. And on top of it, the doctor in the casualty gave him a furosemide shot, which would have drained the chloride from his body and made him retain bicarbonate. And that would have caused acute metabolic alkalosis. So this is and that's the reason this metabolic alkalosis would have then caused electrolyte abnormalities and then caused the brain to become confused. So confusion and arrhythmia was as a result of acute metabolic alkalosis, which was because of profuse vomiting and a diuretic shot that was given. Now let's look at the other patient over here. This is a patient who is a young girl who was a known case of insulin-dependent diabetes mellitus, which we call as type 1 diabetes mellitus. On insulin, he presented with a casualty with heavy breathing, anxiety, excessive passage of urine, and there was a history of not taking insulin. This means to say that she was traveling, and whenever they travel, they somehow refuse to take that insulin because it's not kept in the fridge. Her pulse rate was 141, BP was 150 over 80. She was very cold and clammy with a thready pulse and an RR of more than 40. She received 10 liters immediately because a casualty doctor immediately realized that this is nothing but diabetic ketoacidosis and started the patient a liter per hour of fluid. When he came to the ICU, he was at 500 ml per hour, and on day one itself, this patient received 10 liters of fluid. Now, after day one, this was the blood gas. Now, let's interpret this blood gas per se. This is the blood gas. What's the primary disorder? Well, the primary disorder here is metabolic acidosis. By now, you should know because pH is going down and PCO2 is going down. The primary disorder is metabolic acidosis. Well, what is the response? Now, remember response when this metabolic acidosis, the expected PCO2 is 1.5 into 15 plus 8 plus or minus 2. Well, that's what we're looking at. So let's look at this over here. 1.5 into bicarbonate plus 8 plus or minus 2. When you add this together, we are getting 22.5 to 26.5. And that is why this is metabolic acidosis with respiratory alkalosis, because here the PCO2 over here is 14.3. This means the patient is breathing heavily. The expected PCO2 is higher than that was measured on the blood gas meter, indicating this is metabolic acidosis with respiratory alkalosis. And now the next step 3, was actually to identify the gap. Now look at the gap here. The anion gap mentioned over here on this blood gas is 19.2, which is higher than 12. And that's why this is called as now high anion gap metabolic acidosis with respiratory alkalosis. Now let's go to step 4. The step 4 was to analyze the gap. Now what's the gap over here? The gap over here is measured anion gap minus 12 divided by 24 minus bicarbonate. We just did this equation. And what we found when we put this into this is less than 1. So now what is the blood gas disorder? Well, the blood gas disorder now is high anion gap. This is when it's less than 1, you have coexisting normal anion gap metabolic acidosis. This means to say that this patient is actually high anion gap metabolic acidosis with normal anion gap metabolic acidosis with respiratory alkalosis. Now, this means to say when the patient came in, he was acidotic. Now he has developed normal anion gap metabolic acidosis along with the high anion gap with respiratory alkalosis. Now, why would that have occurred? Very simple. This patient has received 10 liters of normal saline. When you receive 10 liters of normal saline, the amount of chloride in that normal saline is so high that it actually narrows down the gap. So sodium minus chloride plus bicarbonate was the gap that we talked about, anion gap. The high chlorine load has caused hyperchloremic acidosis, which is nothing but normal anion gap metabolic acidosis, which has driven the bicarbonates away from our body. So even after day one of the adequate resuscitation that they had, the bicarbonate on this blood gas is showing only 6.1. However, patient seems to be improving because the keto acids have come down, and this is just a bicarbonate deficit which will respond with some a small dose of bicarbonate. Well, this is one of those complex ABGs that we have in ICUs, and there are many more such ABGs that can come up in the intensive care unit. But importantly, you must remember that ABG is the most common investigation in the intensive care unit, and everyone working in the emergency rooms, intensive care unit, or in the wards should understand how to interpret ICU, an ABG that is done. It gives a clear indication of how the patient is ventilating. It gives a clear indication of the gas exchange as to how much oxygen is going through the capillaries from the alveoli. It gives a beautiful understanding of the acid base status and what has happened to the body and what you have done to the body as a result of treatment. But it is important to interpret all of this in context, and important to remember is it is in a very good window into the status of the patient. Thank you very much for a patient hearing, and do get back to me for any kind of doubts in this matter. Thank you very much.
Thank you so much, Dr. Saseedharan. It was a very impressive and in-depth presentation, and this shows the subject expertise you have. And thank you so much for this amazing presentation. So, now I would like to move ahead with my next presentation to Dr. Kinjalka Ghosh. So, request to please present your presentation, and the topic of his presentation is practical challenges in blood gas testing. Over to you, sir.
Yeah. Okay. So are the slides visible? Good afternoon, everyone. Yeah. Okay. So yeah, first of all, it was a amazing talk by Dr. Sanjith, and he has cleared a lot of stuff. And as you can see, it's not very easy to interpret the ABG results that one gets, and one always has to take it in the proper context. You need to see the patient. You should have clinical information, and it is not just the ABG results that one should. I mean, try to interpret in isolation. So going ahead, my topic is basically practical challenges in blood gas testing. Here you can see an image. Basically, this is how a normal ABG analyzer looks like. It has a portal where it has a needle where you can just put in the arterial blood, and it measures it. So I'll be basically talking about how it works briefly and what are the things that can go wrong, because at the end of the day, when you're interpreting the result, you need the results to be accurate, and there are multiple steps which are associated with this kind of interpretation. Most of them are pre-analytical, that because this is a very good and robust point of care kind of testing device. So you have to be very careful of the pre-analytical errors that can creep in while you are doing a ABG. So I'll move ahead. The principle basically is based on potentiometry, where ABG analyzers use different kinds of electrodes. I apologize for the quality of the image, but you have already seen what are the components that ABG analyzer measures. So you have seen it measures pH, PaO2, PaCO2, and all those things. And so I'll not go into much detail over there. How it measures is basically based on how a pH is measured. So you have pH meters in labs where the pH, basically the hydrogen ion, when you're measuring pH, when you're measuring oxygen, the oxygen ion is basically measured, and there is a gradient that is generated, and there's a membrane which doesn't allow free movement across the membrane, and that is how it measures the available ions that is there. Then it is compared to a standard. So next is the ABG analyzers. you have different electrodes for different parameters. You have a pH electrode, you have a PCO2 electrode, you have a PO2 electrode, and it measures them. Many of these values are often calculated. There are a lot of formula which is there. So what is necessary, like any instrument, the first thing that comes to your mind is calibration. So all these electrodes have to be calibrated with a reference gas or buffer solution, which is basically what it does is it is making a standard curve. It is plotting a standard curve with a known concentration of pure material. And once it is done with that, you are more or less confident that if the calibration has passed, whatever values your ABG analyzer is going to give is going to be reasonably accurate. Second is the temperature. ABG measurements typically happen in room temperature or 37 degrees. There are other components which the ABG analyzer also measures, like you saw in the ABG report, where electrolytes are measured. There are metabolites like glucose, lactate, and sometimes even hemoglobin can be measured. Yeah. So broadly, the process of measuring is basically collection, transport, analysis, and interpretation. You have already seen the complexity of interpretation, and the previous steps, that is collection, transport, and analysis, all of them play a very crucial role in your final report generation. So the key challenge of ABG testing is to preserve the matrix or the values of these components, which should be as much similar as to how it is in the patient's body. So often what happens is when you are collecting the blood sample and you are transporting it, because there will be some distance, even though it is there in the ICU or in the casualty, you may have to carry it a few meters away and you have to measure it. Sometimes it may be in the adjoining room or so. So all those things happen because there are during your transit, the blood is basically also exposed to the atmospheric gases, and that if it is not done properly, if it is not carried properly, if it is not mixed properly, because it needs to be mixed with heparin. Now how you mix it with heparin is important. As you know, blood outside, once it is collected, it has a tendency to clot. So you have to stop that kind of clot from developing. And also at the same time, you cannot have too much of heparin which is left in the syringe, because it will cause a dilutional effect. Your source of collection will matter. So there are a lot of pre-analytical areas where things can go wrong if one is not careful. So the pre-analytical phase is one of the most critical phases. Analytical phase is basically where you are looking at the calibration, you're looking at the QC, and you're looking at the maintenance is being done of the instrument properly. So these are the important things in the analytical phase. And post-analytical phase is the report, and often these things are connected directly to the reporting systems and LIS and those kind of stuff. So you have to be aware that there is no mislabeling or miscommunication happening there. Steps in the pre-analytical phase, like I said, from test ordering to test selection, patient preparation, labeling, sample drawing, all these are critical. Normally, these are much more critical in other lab things. For example, you don't have any centrifugation in ABG, but for other lab tests, it is critical. Sample processing and time. So when you're transporting, and if you're thinking that it will take time, sometimes you don't have a ABG machine in the same building and you have to transport it to the next building, and that is when you have to transport it with an ice pack or something. So that the basic logic is the RBCs, WBCs that are there, they are going to be consuming all these parameters, I mean the things that you're measuring, and also generating many of these components which may affect the pH, which may affect the PaO2 or PaCO2 eventually. So to reduce that kind of consumption, you have to transport it in a ice pack once it is collected. So as you see, collection and handling are the most critical, one of the most critical steps in the pre-analytical phase. So the first thing is when you're collecting, you have to be sure it's a arterial blood. There may be a mixture of arterial and venous blood. Collecting from veins sometimes would give you abnormal values, and obviously the person who is interpreting, you would come to know that it's not a ABG or there is some mixture which has happened. And second is air bubbles. After collection, you have to get rid of air bubbles which are there, because if it is if the syringe contains these kind of air bubbles, it will again affect the PaO2 and reduce the PaCO2. Anticoagulant is important. It has to be done in heparin. The amount of anticoagulant is important. You cannot have syringe where maybe 0.5 ml is heparin and the rest is blood. So obviously you have to get rid of. I mean, you may want to coat it, although you get heparinized syringe. Now things are much more easier. It is probably automated, and the collection systems are better than what it used to be. But you have to be careful. Even if you're rinsing your syringe with heparin prior, you have to just rinse it. You cannot have excess heparin left in the syringe before you're sending it to the analyzer. Delayed analysis, again, leaving the sample at room temperature for extended periods. It ideal is to analyze it as early as possible. If the sample during the process, if there is any hemolysis, it can again affect the readings. That is why to avoid these kind of errors, you have to use proper syringes, you have to eliminate air bubbles, and you have to try to process it as early as possible. If you anticipate any delay, like I said, you can maybe transport it with an ice pack, but ideal is to do it as early as possible. Now, looking at the analytical issues that may creep up, that is, there may be calibration issues. So it is important that the analyzer is calibrated when you're analyzing, and there are a number of days for which the calibration will hold true. So it should not be that you have calibrated once in a year and you're running it without calibration. It won't work like that. There may be problems which have, I mean, there may be actual hardware or technical problems in the electrodes, or there are air bubbles which is slipped in. There is something in the tubing which is giving you a false report. Samples are not proper or ideal. Like, although you have put in the heparin, you have not mixed it properly. And if it is not mixed properly or adequately, there may still be clots even though there was an anticoagulant present. Or else, even if your samples are hemolyzed or lipemic, it can interfere with analysis. Like any other clinical biochemistry analysis, you can have those kind of interferences. There may be a problem with the ABG membrane, and that is not able to segregate like I said, it is a part of your electrodes, the potentiometry, that the basic principle on which the ABG analyzer works. So all those things would give you very much false values, and you have to be very alert because of this. So ideal is daily calibration, QC, it needs to be logged, and equipment maintenance. If these are being done, you can rest assured that your equipment is performing well. So quality control is basically critical. Proper maintenance is important, and whenever you are looking at the ABG analyzer, you have to verify the linearity. So manufacturers often would claim that it can measure from, say, 0 to 100 easily, but you have to actually verify it with those concentrations. And that is part of, if your lab is accredited, you realize that, I mean, whoever is looking into these kind of devices, that these things are maintained and documented. It is always important to see if your system is working well, like any machine. So needless to say, you have to monitor and also document all these things of your ABG analyzer. Yeah. So along with that, that was the internal quality control. Ideal is, along with internal quality control, there's something known as proficiency testing. This is basically like a group of labs which are measuring the same sample, and their results are uploaded, and how you're performing against other labs, that is what is measured. So there are guidelines, CLSI guidelines, which are available, which can guide you to see if your ABG machine is giving you accurate and precise reports. So one of the things is external quality control, and the range that they have advised is the target pH value, whatever you're measuring in those external quality control material, it should be plus minus of 0.4. Your PO2 should be within plus 3 SD or plus 2 SD ideally. So there are different rules that are followed, statistical rules, which helps you align or understand whether your machine is performing as well as it should. So even for PCO2, target value plus minus 8% or plus minus 5 whichever is greater. So the significance is basically, it helps you, because these are like you realize that these are all very emergency situation tests that are being done, and they have I mean, implications on the patient management. So if your values that is being generated are not accurate enough, the interpretation changes. And you saw what ranges, like when you saw the calculations in the previous talk, the ranges are not very big. So if there is a slight deviation on other side, the whole diagnosis can often change, because if you want to see if the person is compensating enough from one kind of acidosis or not, if your accuracy is not of that level, you will have a different diagnosis and the management would not be of the top level. So it is very critical that you measure your performance, you measure you keep your instruments calibrated, you do internal as well as external quality control. All these are critical in maintaining your instruments. Post analytical errors, like any instrument, and depending, I mean, with automation, these things tend to creep in. Most of our samples often are barcoded. There may be mislabeling, like there are two patients who needed ABG side by side, and there's a mix up. Those things, though may seem frivolous, they may happen, but one has to be careful when they're doing these kind of blood collections. Often these results are integrated into the report, so a wrong kind of, I mean, collection and integration of reports would obviously confuse everyone with managing the patient. There is, if there is and it can lead to misinterpretation of the results. So strategies to avoid these kind of mislabeling, you do barcoding is advisable, training, regular training, and often automated EMR entry. It can reduce these kind of errors. So you realize that there are human factors and training gaps which can affect the results. So if you are a NABL lab, and if this is under the scope of NABL or NABH, competency assessment is one of the things which is tested, and along with all the instrument related documents and things that you are maintaining the instrument properly. Staff proficiency is important. So you may have two people starting from the ABG collection, the process itself. There are certain scenarios which I will discuss, and you can see why it is important. um from collection to actually measuring the ABG results. Like you say, there may be stress in emergency situation. A lot of things are happening. There's a lot of pressure. So these places need to be adequately staffed, and then things need to be conveniently placed also. Otherwise, there are chances of errors creeping in. Transport delays, I mean, there's only one guy who can transport it, and the turnaround time of the person may be half an hour. So do you wait? And all those things can affect again. So you have to be very, I mean, the management, this is more of management things, management related issues, where management needs to place the ABG analyzer where it is needed most, rather than keeping it away in a central facility. um, and it should have proper manpower to manage those instruments. So it is very critical, and also all the consumables related to the analyzer often need to be maintained in a cold chain, along with the samples. Like I said, it needs to be transported in ice to prevent the errors from creeping in. This is basically gist of what you have already seen in detail. There need to be algorithms that are in place whenever you are analyzing these kind of reports, and it often helps if there is an algorithm which is there in place. Now, once you realize that something has gone wrong, first thing is to identify that something has gone wrong. If it may be in the pre-analytical phase, it may be in the analytical phase, maybe in the post-analytical phase. So, there, the best thing is to have SOPs. The best thing is to have regular training. Uh, Instruments need to be maintained properly, and to reduce. So now NABL is focusing on risk mitigation. So if you think that there is chances of something going wrong, you can probably identify those potential areas where maximum errors can creep in, and you can work on it, do a corrective action and preventive action that is there. Yeah. So now I'll briefly discuss about 8 scenarios. So first thing is, like, your patient is anxious, patient is breathing because the patient is nervous, and there is hyperventilation. So if you are doing a blood collection on this sample, obviously, without calming the patient properly, your values may be a bit. I mean, it may affect the final interpretation of the ABG report. Second scenario is there are two samples which are stored. So, like I said, ideal is to measure it as early as possible, and if it has been mixed properly, it needs to be mixed. The heparin, although you may have put heparin in the syringe, if it is not mixed slowly by rolling movements of the palm like this, it may lead to hemolysis, or it may lead to inadequate anticoagulation. Both these things would create problems. So patient results from a sample that has been mixed thoroughly, you can see on the table, is giving you a 10 gram per deciliter, whereas that has been mixed briefly because there is a clot which has formed, giving you a different kind of value. So there are a lot of these factors which can affect your final results. Two blood gas samples were collected from the same patient. One is analyzed immediately, other again there is a time gap. It resulted in hemolysis. So again, you can see on the table that there are differences in the values that you are getting, especially in electrolytes, ionized calcium, not necessarily in PaO2 or PaCO2, but there are other things that you are also monitoring. So to minimize this, it is advantageous to use self-filling blood gas syringes. You should follow the SOPs that are there in the lab. Use automatic mixing of blood gas samples if available. And I mean, if you can identify the problem, there are solutions that are there. And ice is obviously, if you're thinking it's going to take long, you should put it on ice. Again, two samples collected, same patient, again measured after 5 minutes. One sample is mixed and air bubbles expelled. In the other, there is an air bubble in the tube. So you can see from the results that the PO2 values would be different. And obviously, this would lead to confusion when the clinician is interpreting the values. So it is very critical that all these steps in from collection to analysis is done very carefully, and all these steps are followed. Scenario 5 again, air bubble is there, so initial PO2 value is giving you 105, because and more than that, here the situation of the ABG analyzer is not where it should be. So the collection, the site of collection and the site of analysis are far away, so it has been transported in a pneumatic tube, and that has led to probably some kind of hemolysis, and it has given you false values that is there, and also it has been exposed to the atmospheric gases that are there. Scenario 6, there are two samples which are collected. Again, one is accidentally contaminated with adjoining vein, which was just next to the artery. And you can see from the table here that you will get different results. Obviously, the person who is interpreting and who has seen the patient clinically would be able to identify that there is a possibility of mixing that has happened here, and it is not matching the clinical picture. So to minimize this, again, there are options which are there. So one has to be really careful from patient preparation, collection, transport. Everything is very, very critical. Scenario 7, again, two samples are collected from the same patient. One is analyzed immediately and the other after 60 minutes of storage, but not under ice at room temperature. So you'll see that the parameters like glucose and lactate, the metabolites that are there in the ABG report, they are affected because they have been exposed to the RBCs and WBCs. And that is why you should try to measure it within 10 minutes or keep it on an ice pack. So impact of non-immediate analysis, I mean, this table is basically representative of that. If you don't analyze it immediately, these are the causes why PO2 can go down, PCO2 can increase. There may be again more acidosis because of increase of carbon dioxide, and glucose has gone down, it has been utilized, lactate has increased due to glycolysis. All these things are basically different factors which can affect your final results. Scenario 8, finally, you can draw a sample, but you have not mixed it, or you have mixed it later on once you realized, oh, I forgot to mix it immediately. This led to formation of clots. And this can again not only give you a false value, but it can also affect your analyzer because there are clots which are blocking the analyzer. And so you have to be very careful and alert. Always ensure that once the sample has been collected, it is mixed properly, maybe by slow inversion or by rolling it between your palms, so that it distributes the heparin, and the heparin needs to be in contact with the blood sample for enough amount of time, so effective anticoagulation is achieved. So these are very critical things one needs to keep in mind when one is doing a ABG collection and sending the sample for analysis. Yeah, the same thing, avoid clotting. Now, one more critical part along with this is the site of collection. Many times you have a collection which is being done from a central line or a catheter, and it has been done after you have flushed it. So there would be a contamination of the flushing liquid, which is mostly normal saline. So there are certain guidelines if you're forced to collect from the central line, what one should do so that the values are not affected. Basically, it advises 6 times the amount of volume which is there in the catheter. It needs to be removed first, the blood of that volume, and then only you should send the blood for analysis. So when using an ABG syringe filled with liquid heparin, you draw the sample before expelling all of the heparin from the syringe. And this has led to dilution because there is excess heparin which has been there, and you have getting a false reading which causes PCO2 value to be lower than expected. So you should expel all the heparin from the syringe before you do the blood collection. Otherwise, there may be a chance of over dilution. So this is basically a list of good practices that you should see when you're puncturing the artery. It should be done in the after you calm the patient. There's no hyperventilation. You should be sure that you are puncturing artery and not a vein. You should choose the correct size of the needles so to avoid hemolysis. You should select pre-heparinized syringes, opt for blood gas syringes, pre-heparinized with dry electrolyte balanced heparin. So there are a lot of options that are there. These are the ideal practices which may or may not be applicable in your setup. But the main idea is there has to be a properly rinsed or heparinized syringe. It has to be, the blood sample has to be collected properly. The heparin has to be mixed adequately. The air bubbles has to be, you should get rid of the air bubbles, and it has to be analyzed at the earliest, preferably within 10 minutes from collection. So in summary, the take home message is blood gas testing requires the person, whoever is doing it, to be very vigilant across all the phases of pre-analytical, analytical, and post-analytical testing. And it needs proper training, QC monitoring, and finally, you need a good clinician for a proper interpretation of the results. So with this, I am happy to take any questions if there are.
Thank you so much, Dr. Ghosh, for this presentation. And I must say, both the presentations were very in depth, and all the case studies were explained very well. And I believe this has been a very understanding and helpful session for all our audience. And we have received a lot of comments and questions out there. So if we can take few of them. Uh, okay, so the first question we have is, can I have this question on screen? Yeah. How important is the role of lab in ensuring ABG accuracy and timelessness? In
Yeah,
any one of you, if you could answer, so
I think I'll take a shot.
definitely, sir. Thank you.
So the thing is, it is basically dependent on the requirement. If the clinicians feel that the ABG machine is not performing properly or how it should function, the lab needs to step in. Ideally, depending on the setup you are in, you can have a person who is looking into the POCT device. Now, the question is basically what is the purpose of doing it? The purpose is to see that proper maintenance of the ABG analyzer is being done. The QC values that are being generated by the ABG analyzers are acceptable, and the calibration of the analyzer is in place. These are the three main things a lab person would look into. Now, whether it needs a lab person to get in and how much time and effort of the lab person is needed is basically going to be dependent on what the administration wants, and what the clinician feels from. I mean, what kind of what kind of ABG reports are being generated from the analyzer. So, if there is no problem in the kind of expected values and observed values from the ABG machine, and it is correlating very well with the clinical picture, it may not require a very big kind of involvement of the lab. Secondly, there are guidelines which may say so, like if it's a NABH accredited lab, NABL accredited lab, and you are putting POCT under the scope of NABL or NABH, where it needs to be monitored and documented, then the lab has a much more bigger role to play and to maintain all those records. So there are two aspects. Is it needed because the values are not accurate, or is it needed because you need to have a kind of documentation or accreditation purpose. So these are two different things. Ideally, it may help if the lab person speaks with the clinicians or the emergency setup, and you can have a discussion. You can have a coffee table discussion and ask, do you feel your ABG values are good enough or not? If they're okay with it, you can just have a look once, and it depends how much involvement the clinician wants from the lab also. It's a both way thing. Purpose being, the values need to be accurate enough, and there are many things that can go wrong. You can always see. So if it is all in place, it's fine. So communication is key. The interdepartmental communication needs to be there.
Thank you so much, Dr. Ghosh, for answering that question. We have another question. What is the role and importance of methemoglobin? Dr. Saseedharan, if you could answer this question.
Yeah, so we do have a lot of therapies that we're using nowadays when it comes to treatment options. For example, we at times are using we are using methylene blue for the treatment of sepsis, which is something that we've been using even from COVID times, and sometimes when we overdose that particular treatment, we might land up with methemoglobinemia. Now, importantly, what we must understand is even certain toxicities like cyanide toxicity that also presents with something like methemoglobinemia, where the saturations artifactually get stuck at 85, 84 percentage, 88 percentage, and you might think that the patient is actually hypoxic when the delivery of oxygen is pretty okay. So, the methemoglobinemia, though, is not a persistent problem or a very common problem that we have in the intensive care unit. However, the correct or a good physician would actually keep a watch on this, because there are nowadays therapies that we are using where methemoglobin goes up. Dyshemoglobin homonymous per se in the population is very, very less per se. Yeah.
Thank you so much for that answer, sir. We have another question, that why are electrolytes result different from ABG machines and electrolyte machine? Dr.
Yeah.
Ghosh, if you could
Hmm.
answer.
Yeah. So they're basically different because, yeah, they're different because there are broadly two different principles at play. The ABG analyzer uses a direct ion selective electrode, whereas the most of your auto analyzers use an indirect ion selective electrode. The difference being, in the indirect one, it's not a direct measurement which happens; it dilutes with a buffer, and after that, there is an indirect measurement which is happening. There's a slope which is created, and that is why you're going to get a different kind of value. Now, if you ask me, the more accurate value is the direct ABG values that you get from the direct IAC instruments, and that is the more ideal one. There are also different factors which may give you, like the one we encounter. You may have a pseudo hyperkalemia kind of case, which your standard analyzers would give you a elevated potassium level. Now, when I'm saying pseudo hyperkalemia, that means the patient is not showing any signs of hyperkalemia, and whatever has happened is the blood in the tube is showing increased levels of potassium in the serum. So, um, when you are measuring it, the same values on a ABG analyzer, you will probably get a normal range. Reason being, it is when you're doing dilution, if there is a small amount of error that is present, it gets amplified. So there is an indirect kind of measurement, even a small error is going to get amplified. Whereas when you're doing a direct IC, that error is not going to happen. Now, the commonest cause of pseudohyperkalemia in our hospital in Tata is because there is increased number of WBCs, especially in AML, CML, which are fragile. And we are doing a serum. That means when there is a clot retraction and there's centrifuge, the WBCs rupture. Unlike RBCs, when there is hemolysis, which is visually, you can see that hemolysis has happened. When WBCs break down, you can't see. You won't know that WBC are broken down. But as you know, in the intracellular compartment, you have more amount of potassium than there is in the extracellular compartment. Same holds true for WBCs also. So you realize that, yeah, the values that you're going to get on your ABG machine and in the lab, central lab, is going to be very different, and the lab is going to be blamed, saying, "Oh, you got very wrong high values," and that is where the communication is important. And one way to sort it out is, if you are suspecting a pseudo hyperkalemia kind of situation, you may ask for a fresh sample in a heparinized tube. again, thing to note is when you are comparing the lab values, it may not be a heparinized sample, it's a serum sample. Although some labs do use heparinized sample, whereas the ABG is always a heparinized sample. So you're going to have a different matrix. So measuring serum values with plasma values. Normally, due to the matrix, you have a 5 to 10% difference. But when the lab asks a fresh sample, you should ask it preferably in a lithium heparin bulb. In these kind of scenarios, if you're suspecting a pseudo hyperkalemia, and what it does is you're not, I mean, you will reduce the amount of WBC lysis because you're not there's no clot, and chances of lysis or WBC is less. And what we have observed is effectively you're going to get a normal value or a value which is more than 10%, which can account for just matrix variation, that is between serum and plasma. So mainly because of difference in technology and other factors which can affect the values, being comparing serum with plasma, you would probably get different values when you compare ABG values with electrodes that are being used in your auto analysis.
Thank you, Dr. Ghosh, for that answer. And we are left with one more question. What are the most common pre-analytical errors you observe in ABG testing? Dr. Saseedharan, if you could answer this.
This question is basically should be addressed by Dr. Ghosh itself. Dr. Ghosh,
Yeah.
please go ahead with this question because this is something that you would be able to
Ah,
answer more than me.
Yeah, so like I said, the commonest ones are basically when there is inadequate mixing, there is a big time gap, and there is a clot, the small amounts of clot which are there, and wrongfully it is not a ABG blood, it is a venous blood which has been collected. So these things are the commonest things that I said in my presentation also. The most common pre-analytical errors are basically from improper collection, storage, and transport. One has to be very careful in these things, and mixing. If you don't mix it properly, this is what we observe in our place. I think,
Dr. Ghosh,
yeah,
if there's something that I could add over here. So something
please,
that I
please, please,
feel will probably change the way you look at blood gas is actually looking at point of care. So one of these, movements that you have, that because of which you have to take and it takes time before you actually process the sample, could be cut down only and only when there is point of care analysis. And I think POC, point of care
yeah,
ABG, is the one that has actually changed intensive care management per se because it just allows quicker decision making with respect to
absolutely.
ventilation, with respect to drug doses, with respect to therapies, and it also helps us to trend values very quickly and also monitor treatment
Make decision.
effectiveness.
Yeah, absolutely, absolutely. So that's what I said. I mean, the AVG machine has to be placed where it is needed most. It should
Correct.
not be in the lab. It should not be in the lab. The AVG
Hmm.
machine should be near the patient.
Thank you so much, Dr. Ghosh and Dr. Sasidharan. And with this, we have come to end of this session. And I would like to thank all my audience for joining in and for asking those questions and for the amazing comments which we are getting here. We hope the discussion offered a valuable insight into atrial blood gas interpretation and its practical application in critical care, from real world and case analysis to evidence based decisions making strategies. And today's session reaffirmed the importance of accurate, timely ABG analysis at the point of care. And the credit goes to our speakers here who presented this amazing presentation with the case studies and every possible aspect of this. A special thank you to Dr. Sanjith Saseedharan and Dr. Kinjalka Ghosh for the efforts they have put in. So thank you so much for taking out time and sharing your expertise with us, sir.
Thank you. Thank you so much.
Thank you so much to all. Thank you.